All right, so Recipe for Health, we're here for workflow training. Prescribers with MAs and MAs. This is really about the operational pieces in the EHR. Where do I click? And then connecting that to the operations of the clinic. And so hopefully this will take care of a lot of questions that may come up in the middle of clinic. So here we go. The kickoff we've done. So that was to get everyone excited. It's a short burst of what it looks like to experience Recipe for Health, especially if you're referred to the health coaching. Today, we're focusing on workflow trainings, and it's the epic side of the house and operational integration. We will be scheduling a session on the actual mechanics of how do you, especially for the MAs and the prescribers without MAs, like Dr. Frankel, Michael, et cetera, how do you screen for food insecurity in a culturally humble way? That's not today, though. Today is just about the mechanics, so you're comfortable in clinic. We've done also the clinical nutrition element. We've done the intro, and then we'll have just some maintenance sessions that we'll schedule with Dr. Sujimoto, Naz, and Amel. Feel free to jump in with any questions. Here's just to be clear, like you're here, you're showing up, like, why am I here? Am I in the right room? If you're a medical assistant, you definitely should be here, all medical assistants. If you are a prescriber with MAs, and we have most folks here, I don't think you have a lot of women's health folks, but certainly they're welcome to participate in the program. You just got to get trained up. And then this is the X factor for most clinics, prescribers without MAs. It's different at every clinic. Some clinics have a lot of behavioral health support or have somebody like Dr. Frankel and Michael, others don't, or they have coordinators. We have nurses sometimes that are in blood pressure clinics, managing and wanting to prescribe, nutritionists, which I know you all don't, chronic care assistants, population health, acupuncture, CHW. So this is variable. So if you are listed here, you should be here. And if you're not, you should let us know, and we can add you to the list. So what's the goal of today's training? At the end of the day, I'm going to throw a lot of slides, a lot of information, and I want you to interrupt, especially anytime it's unclear. It's about understanding the workflows, and there's really two big buckets: food insecurity screening, navigation, how to find things in the EHR, and referrals to CalFresh and Recipe for Health. And Recipe for Health is that combined food and health coaching. Awesome, Kim. It's true. I do get OB folk, the women's health folks train who have been sending us referrals. So it's great. But I know there's been a lot of staff change. So this is it. At the end of the day, you need to walk out feeling you know who's doing food insecurity screening and how to do it in the clicks, and then who's doing the referrals and how do you set your team up. That's really an ask of the MAs for the pending piece to help do the team-based care. All right, here we go. Outline, 3 parts. I'm going to quickly do an overview just because I know some folks are new, roles and responsibilities, and then putting workflow into action. So what is R4H and what is it trying to address? Again, you've seen me talk about this. I mean, I've condensed it to like 2 slides. When you're talking to your friends, you're like, what do you guys do at Lifelong? What's this Recipe for Health? You say it's an integrative model of healthcare. It's us in healthcare standing up to use food as medicine to address 3 things all at the same time, right? Not just downstream medicine, but food and nutrition, insecurity, other social determinants that are upstream. Chronic conditions, which is our bread and butter, both behavioral as well as physical health. And then also health and racial equity. And by doing that, we have, as we're evidence now, this is now covered benefit in Medi-Cal. So your patients get this prescribed. And this is really for the MAs. This is really important because the MAs, to hear this, your patients can now get prescribed this Recipe for Health in the same way as they get prescribed blood pressure medicines, cholesterol medicines, diabetes medicines. It's all covered. It's free. So just to punctuate the point, what do patients get? Literally, if you're in the middle of clinic and you're like, what is this Recipe for Health? It's free food and health coaching. It's free food and health coaching to be used in a clinical setting. It's not food bank. This is using it for your patients with chronic conditions and when you diagnose food insecurity. Food and health coaching. That's what you got to remember when you're in the middle of clinic. All right, 3 ingredients. We've done this before. I'm going to throw in this third piece. The recipe for health flow is food and health coaching, but we also blend in CalFresh, because the question has always been, well, what happens after the prescription runs out? And so we want to get folks into CalFresh. So we have 3 ways to create infrastructure for you all. One is our food pharmacy, regeneratively grown organic produce. Regenerative, focus on soil health and the environment, and taking care of the land. When you do that, the nutrient density goes up. With no pesticides. Organic, also reduction in pesticides, but it allows for some 25 different pesticides. So we're going to 0 pesticides. So great for your pediatric patients, great for your OB patients, especially. Doorstep delivery to their home. We have 12 weeks now of an initial dosage, and we've heard from the health plans that we can do refills. So I'm going to talk about that. But it's going to come through a very focused pathway. A behavioral pharmacy. Now, MAs, this is really important. I hope when you guys talk about the food and the health coaching, it's group and individual coaching, and it's fun. They're moving. It's what you did at the kickoff: nutrition, stress, social connection. 3 options. Remember, there's 1 at your health center. You guys are lucky to have 1 at your health center. If they can't make it, they have a county-wide group, and then there's individual coaching, and then what we're doing together. And you'll see that I highlighted CalFresh here. So I'm going to talk more about CalFresh today, but the nutrition training will be later, just the maintenance stuff. And then this is all about EHR, making this as easy as possible. So what's in a bag of food? Many people say, great, I got the food part, but what are the patients actually getting? These are just some pictures. You know, it's a bag of food once a week. It's all fresh, regeneratively, organically grown food. It's 16 servings of regenerative and organic veggies. And remember, 1 serving, 1 fist is enough to reduce death by 5%. So it is a strong medicine. We don't think about it that way, but that's why we're doing this work. Health coaching, 3 options. I've shared them already. There are your group, which at your health center is Wednesdays, 8:30 to 10:30 in the morning. If they can't make that, or they speak Spanish, and this is where we want to highlight, especially for lifelong. We have Spanish groups. We haven't gotten any referrals for Spanish-speaking patients, or it's been very little. That's the feedback we've gotten. So we just want to make sure you're aware, MAs and providers, prescribers. Recipe for Health can go for your Spanish-speaking patients, Arabic-speaking patients, other patients. We have it in Spanish. It's in the evenings. It's been really great because of the time. We also have a county-wide one that's in English. There's no medical provider in this one. There is a medical provider here, but it's all group-based. And for those patients that are shy, they don't want to be in groups, we'll finally offer them individual coaching. The bottom line is you don't have to worry about all of this. You just need to say, I want to get my patient into Recipe for Health. They'll get food and health coaching, and our team will call the patient and get them set up on Zoom or get them in the group. You know, we do all the background, so you don't have to spend a lot of time in clinic thinking through this. All right. So what happens with your referral? Because people wonder, okay, I sent that referral, but how long do I wait? Is it happening? Is it not? Just so you all know, when that referral that Dr. Sujimoto or Dr. Perry sends, or Michael sends, or Bonnie to R4H, you do it anytime during the week. We get it sent to us as a package once a week on Mondays. It actually comes in automated at 3 a.m. We get that. We prepare it in the format that the health plans want. We make sure that that it's as clean as possible so it won't get rejected. That's where we need your help, and that's part of this training. We send it to the health plans for authorization. We send it to DDF, Dig Deep Farms, and Open Source Wellness too, so they're aware of these patients coming in. Outreach to the patients occur within 3 to 10 business days. If you send it on a Friday, we get it on the Monday, and we literally can get it out in business days, not the weekends, as early as 3. It's probably a little longer than that, but also as late as 10 days, business days, but usually it's a lot earlier from the date of the original for referral. Dig Deep and Open Source Wellness will each call the patient. We do aggressive outreach, 3 attempts to enroll the patient. They even text them. Dig Deep texts them as well. And then the food, once the patient enrolls, right, they say, yes, I want this food and health coaching. Then once we get the green light on that, we will then, the food will be sent to their home. It's usually no later than 2 weeks, but it's within that time. But they need to say yes. You know, if you all do the referrals and the patient never responds to the phone call, never responds to the text, our team has no idea where to drop the food off, who to call to get them in. Remind the patients then to respond to the text or the phone call. Any questions so far? Okay. So I talked about food and health coaching, but I also talked about CalFresh. Can you all tell me what is CalFresh? Can someone just shout it out or type it out?
Food stamps.
You got it, Taylor. It's what we've called food stamps. In the nation, we call it SNAP. In California, we always like to rename things. We call it CalFresh. It's $200 to $400 a month, potentially. Sometimes less, depending on your income and all, for food that they can use to purchase other food. And it's a longer-term food security pathway beyond a prescription. So we are aware of that, and we're trying to integrate this. So we have a referral. Your MA, when the MAs, identify that food insecure patient, boom, you hit that referral to CalFresh, and you're wondering, okay, what happens? It just get in the ether, in the ether or whatever. Well, it actually goes to your eligibility department. They have a work queue now in Epic. We've built all of this, and they will call that list and assist the patient to complete the online application. Once that's done, once we at the health centers have done that, that application is sent to my colleagues at the county, at the social services, to get the patient in. Great question, Yasmin. Do they leave voicemails? They do leave voicemails when they do outreach. And thanks, Anna, for explaining that. I didn't see you responded. So that's it, part one, you all. Any questions on the program so far? Okay, roles and responsibilities. Now we're getting into the nitty gritty, right? You guys should know a lot of this because you're doing it. We're in that hybrid space with Lifelong, with new providers and old providers being there. I want to make it as simple as possible. And so this is for everyone on the team now. There's 3 workflow steps, simple, 1, 2, 3. So the first step is you screen for and add a diagnosis for food insecurity if it's there. Screen, add the diagnosis. That is the MA. So the MA, you're going to own this. You're going to own screening at every visit, not once every 3 months, not once a year, every visit. That's what we've heard from the MAs at all the health centers. They want to make it routine, like asking about smoking. And I think Amel has created pathways with whatever your list of questions you all had. This is built into that as a reminder. And it's also for the prescribers without MAs, the acupuncturists, the CHWs, case managers, whatnot. So you screen at each visit. The treatment is the number 2. That's number 2. It's the simple number 1, 2, 3. You're treating food insecurity and/or chronic conditions with a referral. So we're using that referral, and we're calling that a prescription. We're using the referral mechanism in Epic. And there's just 2 referrals. It's CalFresh and Recipe for Health. Your MAs, there's a bridge here between 1 and 2. The MAs will help pen the order to help remind the provider that this is the case for food insecure patients, but we need you providers, prescribers, chronic conditions, and I'll say why. And then resources and reminders. The MA will have this to go over the after visit summary and reinforced by the prescriber. 1, 2, 3. Let's walk through it. Who's being trained again? You all know this, just as a reminder. MAs, prescribers with MAs, prescribers with MAs and without MAs. So let's go through the first step. Screen for and add diagnosis. This is where we want the MAs to perk up, ask a lot of questions. Also the prescribers without MAs. If you are a prescriber, because we actually have a prescriber at another clinic, and they are like the champion. They just like, oh, it's for, especially for telehealth, because they don't have their MA with them or something like that. They basically are the ones screening. So certainly we're not stopping prescribers from doing that, but we're trying to create that team-based care where MAs are doing certain things, providers doing something, everyone knows who's doing what. So communicate that in your dyads and your huddles, however you want to do it. But the bottom line is, at minimum, the MA and the prescriber without MA. So here's what it looks like. There's this may look different for lifelong, but this is just one of the clinic images I got from Bach, Bay Area Community Health, and your sister clinics. So when you're trying to figure out, does this patient have food insecurity or not, MAs and prescribers of that MAs, there's 3 locations. What are the 3 locations? Do folks know? Any MAs want to respond? Text or chat or call or speak up? Okay. There's this one right here. This is the knife. You'll see a knife and fork. This is called the storyboard. It's that patient and a bunch of information, a bunch of the social determinants of health here. If it's lit up, this means if it's orange, that's a positive for food insecurity. That means they've been screened, but you still want to screen them again. Let me say that again. They may have been screened, but you see them in a month, screen them again, especially because we've learned that during COVID, people go in and out of food insecurity. Green fork, they're negative. Great, they're doing fine, but maybe they just lost a job, so you want to screen them again. And then gray fork, it just has never been done. The second place to look for it, this is where once the MA has done this, so prescribed with an MA, if it's positive, this is where you just add the diagnosis here, and you'll see here, it shows up on the food insecurity in the visit diagnosis. So that when prescribers come in, they're like, oh yeah, this is awesome. I don't have to do that. My team member helped out and took care of that. And then the third part is over here on the right. You'll sometimes see that the MA has prepped it. They've created, they've pended a referral to the Recipe for Health. This is an old one here. It shouldn't say food pharmacy. It'll say just our whole food and health coaching, and then referral to CalFresh. Okay. So that's where you find it. You're just wondering, oh, who has food insecurity or not. First thing is check. Second thing is, how do you screen for it? And this is how you do it in Epic. There are 2 questions, and I'll show you but what are the questions? We like to, this is not built in your EHR, and I know you guys are using handouts, the MAs, so we try to normalize it. So we have a lead-in question just to normalize why we're asking. We ask all our patients about food, about access to food because it affects health. We want to make sure that you know about all available community resources. We're going to go through a whole training on how to do this in ways that are helpful. And then here's the instruction statement for the MAs and prescribers with MAs. I'm going to read you 2 questions, right? Some people have made the following statements about their food situation. For each statement, I'm going to read you 2. Please answer whether it is often, sometimes, or never true for your household, not just for you, for your household in the past 12 months. And then it's 2 items. Within the past 12 months, you worried whether your food would run out before you got money to buy more. You worried. This is about worry, mental load. The second one was, within the past 12 months, the food you bought just didn't last. You actually ran out and you didn't have money to get more. So one is worry and one is the actual situation. Any of these, if they're positive, sometimes or often, you have a positive food insecure screen. All right, so let's get into the mechanics. Where is all of this located? The MA should know this, but and prescribers of that MAs, you may know this too. This is part of the standard workflow of the MAs. They go through screenings. If you go down to your select social determinants of health, you'll find food. You click on food. When you click on food, the 2 questions pop up. Some people have made the following, statements about their food, but it doesn't have the lead-in. It has the instructions and it has a 2, and you can click. Now, if you're doing this as a telehealth visit, you can ask your questions on your little, you have a little dot phrase, and then fill it out here. And so you just enter what it is. Again, we're not making you remember much. If you see an exclamation mark here, it's positive screen for food insecurity. When you screen a patient as a positive, add the diagnosis for your prescribers. MAs, add the diagnosis. You're allowed to do that. We've already gotten clearance from everyone. You just add it, and you add it to the visit diagnosis, and it'll pop open the prescriber, opens the chart. Questions on this? MAs especially, this is really important. Okay, let me keep on going then. So we just finished the first step. Easy as 1, 2, 3, right? All right, treat. food insecurity and or other chronic conditions. I really want to emphasize the chronic conditions, only because that's where folks are forgetting to add that in, and then we're not able to cover it by the health plans. So this is for all prescribers. Everyone listen up here. And then MAs, you have a part to play with MA Assist. So here we go. Referrals, one of the first referrals is the CalFresh, and the MA has a pathway to pend, the prescriber can sign. This is my line. You guys will have your own line, but this is my line that I often recommend to the MAs if they screen positive. Would you like help on getting extra monthly income for food through a program called CalFresh? If yes, then place internal referral. MAs, what do you all use? Or prescribers of that MAs, when you're introducing the concept of CalFresh, how do you say it? I know there's some veterans among you who've been doing this. So any tips to share with your teammates? Okay, it's quiet. Amel, you can jump in too, if anytime. So there's the order when you're actually, if you're going to place that internal referral, that goes to that list of internal referrals, and we've already built this in, referral to CalFresh. It's one click there. Once you've done that, this is all, you don't have to put anything in here. This is all automated. All you do is click accept. Done. It goes off to eligibility. Eligibility works that list, tries to get your patients into CalFresh. Questions? All right, we've done part one, or half of the referrals. The next one, oh, and then by the way, this goes to the pending. So this is where it splits. MAs you'll pend. Prescribers without MAs, you're just going to go straight to signing the order. You can do that. Questions on pending, team? There's a role for MAs in helping the prescribers. Are we good? Okay. For CalFresh, the other thing is just to remember, when you're just doing the CalFresh piece, just associate the diagnosis with the food insecurity. So you may have your provider may have a bunch of other things, or it's actually zero, there's nothing here. Just remember to add your food insecurity and click it, and you're good to go. Then it'll come over with the right diagnosis. All right, second part, you're now referring to a recipe for health because the MA is saying, oh, you're food insecure, I want to get you into CalFresh, but I'm going to potentially set you up to get the rest of recipe for health. Or you're the psychiatrist and you're saying, not only are you food insecure, but there's some other resources we can get you with recipe for health. So again, I'm just going to say you can use these and or not. Your provider may prescribe you 12 weeks of free, organically and regeneratively grown vegetables delivered to your home to improve access to healthy food. Any objections to this? Some of your patients may be homeless. They may say, I can't accept the food. Then you don't need to move forward. You can just flag to your provider, your prescriber, can't do it. It's not a good situation. But most folks will be open. And if that's the case, then you go in there and you click your referral to Recipe for Health, Food, and Health Coaching. That's the current referral. And then this is what's going to pop up. And there's two selections. There's an initial and an extension. Do not touch the extension. Just focus on the initial, if you even have to do that, and then click accept. And that will, and then append it. Will is asking the question, do CalFresh and Recipe for Health have to be linked? As in, do we refer to both? We are recommending that you refer to both. But in this case, sometimes it can be delinked because your patient may have already gotten CalFresh. Like, no, I'm good, I don't have it. Then you don't have to make the referral. Or they are saying, I don't have capacity to receive food. And in that sense, you don't need to. But we're trying to encourage folks just to think of it as a package. Other questions? Appreciate the question, Willa. All right, thanks. So let's talk about that initial referral. When you click that radio button, initial, this is what pops up. You have all seen this. There's a lot of language. It's pre-populated for you, so you don't have to do anything. The idea of us pre-populating this section is just if you're like in the middle of care, you're like, what conditions qualify again? We've worked it out the health plan, but this is the language that they want. And there's metabolic conditions, all the diabetes. I'm going to flag pre-diabetes. We're in discussion with them as to if they're going to continue to cover it or not. Overweight, obesity, metabolic syndrome, polycystic ovarian syndrome for women's health folks, fatty liver. There's something for everyone, because food is critical to all these things: hypertension, CHF, stroke, heart disease, arrhythmias, lipid abnormalities. The literature is there to show that there's benefit. It's like a medicine for these conditions. And many folks wonder, what about mental health issues, depression, anxiety, eating disorders? I've treated patients who have had eating disorders as part of the group at your clinic, and it's been powerful for them, at least what they've shared with me. But certainly depression and anxiety, if there's a food-based component to it. Not everybody, but there may be, right? And then high-risk perinatal conditions, GDM, preeclampsia, pregnancy-induced hypertension. We have this big other bucket: HIV, cancer, asthma, COPD, and emphysema, irritable bowel syndrome, mild cognitive impairment. If any of you have elderly parents who are going the dementia pathway and they're beginning to develop this state called mild cognitive impairment, a great opportunity to use food as medicine to shift that. Chronic kidney disease. So extension, just so you all are aware, we don't want you to click it. We're going to have to up it. It initially said 4 weeks. This is my opportunity to remind folks that, or to share with you all, we now have the ability to offer us a refill. We now have the ability to offer a refill of the 12 weeks. So they get their initial and they get another. We are rolling it out slowly and methodically because we're working the details out with the health plan. But in how we've set it up, and we're actually doing it right now, is we want to provide an automatic extension for an additional 12 weeks for patients who are diabetics. You guys have refer a bunch of diabetics, and then others identified by Open Source Wellness, because they meet with them weekly and they can say, this patient is super engaged, they're going to benefit, they want it. Remember that this is all based on medical necessity. So because of that, we are going to automate this for diabetics. And what we're going to put in that language in our chart to back to the health plan is the following under your name, under the prescriber's name. I reviewed the patient's medical records and attest that the patient meets the medical necessity criteria for an extension of medically supportive food and nutrition services. The patient will benefit from an additional 12 weeks of treatment to stabilize and improve the chronic condition. If the condition is totally good and perfect, reversed, they don't want you to necessarily do an extension. But in this case with diabetics, because we recognize it takes time for that integration, we're going to go with the diabetics first. Any questions? This is like breaking news. Did that land? Are folks clear? Good with that? Most of your patients will get to 12 weeks. We're going to automate it for those who are diabetics. Thank you, Miriam. All right. Hopefully that's happy news for folks. We're gonna get feedback along the way and adjust with the health plan. So I want to do one nuance, because I know our whole model. Thanks, Mike. Our whole model is to kind of break the mold and say we are broadening who is a prescriber. Non-credentialed staff who are touching patients in a clinical manner, who can connect people into food and health coaching. We've broadened that. Now there's a few one step that we need these non-credentialed staff to do, and that is to enter the PCP's name. This is what leadership at your clinic has suggested, and so happy to hear feedback. But the idea was to, if you're a case manager or CHW, when you click through, there is a section called by provider, and you would search for the PCP for that patient at the time of order. So you're working again on team-based care on behalf of your patient, of your providers. Question from Bonnie: what if we want them to get extensions like eating disorders or other? So for now, Bonnie, we are just unveiling the 12-week extension. And so we're very focused right now on diabetics. We will, as we get the data and work out the kinks, we will come back to folks and think about if there are going to be other pathways. But remember, your health coaches know your patients really well, and they will be making recommendations too. But this is really key for folks like you, Bonnie. I think unless you're credentialed staff, we need all the credentialed staff to put the name of the PCP here. If you don't, what happens is somehow we don't get the name of the provider, and then it gets denied. So we're trying to save you the pain of doing that. We haven't had too many issues at Lifelong. Let me ask the question, who of you are non-credentialed staff? Is there anyone in this room? Amel or Dr. Sujimoto or Naz, do you all know who is considered non-credentialed staff at Ashby? Okay. Well, if this comes up, let me know. Can you explain more about credentialed staff? LCS, okay, thank you, Amanda. So you are credentialed staff. There's certain things in the medical world where you have to be credentialed, or you get credentialed, you have a licensure, and you're a typical medical provider. Any MD, DO, midwife, NP, PA, psychiatrist, LCSW is credentialed. What is unclear to me is if coordinators. I think most coordinators are not. So if you're a behavioral health coordinator or you're a case manager, you do kind of work around the patient, but not direct kind of typical patient care. Then you are non-credentialed. So it sounds like acupuncturists and chiropractors folks are credentialed. That's great. So you don't have to worry about this step. Amanda, you don't have to. ASWs, Willa, let me ask Anna and Joey, if Willa has Willa, who's an ASW, have you seen a prescription from her, a referral? If you've seen her name? And then Willa, have you made a prescription to us? Okay, so ASWs are credentialed. So I think you don't have to worry. Anyone who's credentialed, it automatically populates your name. Okay, thanks so much, Willa. I'm pretty sure I've seen it, but I wanted to confirm. Okay, so does that answer the folks' questions? Just trying to make it as easy as possible and minimize the rejections. Okay, and you guys are doing great. So just, if you are a non-credentialed staff, put the name of the PCP. This has nothing to do with MAs, okay? This is more for the people who are going to prescribe. All right, here's a key piece though. This is really important feedback because we have a lot of new folks at Lifelong, and we don't always see this happening, but I know it takes practice. So I'm just gonna hit it again. Prescribers must associate chronic conditions to the referral when indicated. So the reason is only chronic conditions will be covered by a health plan. And so we are using scarce resources to cover the other condition, which is food insecurity. All of this will be covered. If you do this, you associate the chronic condition and you do the second part I'm about to go into, which is make it show up in your assessment and plan, golden. It flows through, there's no rejections. If you don't, then we spend time kind of chasing you guys down, working with you all and your leadership to kind of close the gap. So food insecurity by itself will not be covered, but we are committed to taking care of folks who are food insecure. So we are trying to find grants and a bunch of things to cover those patients. But there's a lot of folks who are food insecure. So I'm just worried a little about funding, right? So that's always a worry in my mind. So do your part as much as possible. When there's a chronic condition and you think they're going to benefit, put it in. You can put a 2 or 3 of them. It's okay to put a number of these all in. Better to put more than to put none. All right. So this is the second part. Associate the chronic condition in the referral. And this is your second key. If you do both of these, we're golden. It just goes through. You list the diagnosis in the assessment and plan. Now, I'm going to ask you all questions because there's different ways to list diagnoses in the assessment and plan. I'm just going to show the ways that I do it when I'm in clinic. Sometimes I do free texting, right? Because I'm copying a note over. But there's that whole dot phrase called dot diag med, right? And if I put that in, then it populates that encounter, that note, with whatever visit diagnoses I put in. So I'm just going to unpack that a little. I can free text it and just write diabetes. That's fine. I can write obesity, I could write this, just free texting. As long as it's in your assessment and plan, when the health plan looks, they'll say, oh, okay, they associated the condition on the referral and it's documented. This is called supporting documentation. What we're finding is some folks, the MA set them up for the food insecurity, but the providers forget to write this in the assessment, and then it's held up. So do both. And how it works if you use the DiagMed is it'll take associated conditions. So if you write it in your visit diagnosis, it will populate it over. It'll grab it. And then if you just go straight to the associating the diagnosis here, then you're good. So it'll do visit diagnosis and associated diagnoses when you do referral, and that'll decrease denials. Let me pause here. This is really important. Questions and other pathways. Maybe you all have figured out other ways to document it in your assessment and plan that I don't know about. Other ways you all put it into your assessment and plan. This is really for prescribers and prescribers without MAs. MAs don't have to worry about this because you're not usually writing. You guys have done your part in identifying and screening every patient and pending the orders for CalFresh. Is this what you all do? Do you all free text or you guys use Diagnosed Med? Can use assessment and plan from the problem list. That is great. I don't know that pathway as well. I do see a lot of notes that do that. So if you do that, I think it populates your SOAP note, right? You'll see the diagnosis. Is that right, Dr. Sujimoto? If you just click the button in assessment and plan, there's some type of button that will populate it into your encounter or into your visit. Oh, Julie Marino, assess plan. Oh, that's a new one. I'm gonna have to explore that. But as the bottom line, and thanks, Dr. Perry, the bottom line is you got to have it in your assessment plan. You can't just throw it into the referral. Go ahead.
That dot phrase brings it in from the problem list.
The assess plan Porcho?
Yeah.
Okay. Hey, team, can we kind of write that down? I want to include that in future trainings. It sounds like that's not just for lifelong, it's everywhere. So that's great. That's how you get the problem list in. Awesome. Thanks, guys. Going to keep on going. Sometimes, though, you will make a referral, especially case managers or prescribers without MAs, or even prescribers with MAs, where you're not seeing the patient in clinic. You get a lab or you get a phone call, or the patient hears about it. They're like, hey, can I get in? You review the note and you're like, yeah, this patient has diabetes. All that the health plan now wants for these interim notes, because they're not full notes, they're not usually a SOAP note where they can look at all the documentation. They want two things. They want to make sure that you put the diagnosis in. You can't just say patient wants to be in respiratory health, get them in. You have to actually have a diagnosis, and you can look at that list: diabetes, hypertension, depression, anxiety, whatever. And then you want to. They need you to say the status. They need you to say in the interim note, not the SOAP note. The SOAP note has all that information, rich data. They're like, good, you've demonstrated. But for these short notes, they want to know the status that demonstrates that the condition is not at goal, even if it's improving. You don't want to say improving or at goal and then prescribe, because they'll be like, well, why are you prescribing? They're good. You say they're improving, but they're not at goal. So if the condition is normalized, the health plan may say, not sure your patient meets medical necessity. Sounds like they're good now. They don't need it. It's kind of strange, because sometimes you think, well, I want to make sure it goes for another 3 months, right, on their diabetes. So here's some of the language that we all do naturally, and this is prescribers, not for MAs, or prescribers and prescribers without MAs. Diabetes, just but not well controlled, or if it's status shows hospitalization or poorly controlled. You can even say poorly controlled per recent labs as if you're referencing. If you want to put the hemoglobin A1C value, great. It's helpful. It's not required though, but it is helpful. Obesity, worsening per BMI, or obesity improving but not at goal. You can put the BMI in there, or you just put the BMI, like BMI 40 or 30. That's good enough. They go, oh, I know the status of the patient. Depression, worsening per PHQ-9. You can put in the PHQ-9, or you don't have to. You can reference it. Or improving but not at goal. Are we good with this? This is just interim notes. A lot of the prescribers without MAs tend to do a lot of interim notes. Most of the prescribers with MAs are in clinic and they're doing it. But if you do it in between, you get that phone call, here's the pathway in. Good? Thumbs up,
I have a question. It's
please. Thanks.
I'm not used to, like, I typically don't document depression in this way, like improving but not at goal or
Okay.
like I will list the symptoms or the continued ongoing symptoms. Is that something that like the health plans recognize as sufficient?
Can you give me an example, Amanda? I love this question.
Yeah, so I might say like, patient has been more isolated over the last week, and stayed in the house like for the last 2 weeks, right? And then
Yeah.
I'll put underneath that line like current symptoms, isolation, withdrawal, fatigue, insomnia, like
That's
whatever
good.
it would be.
That's more than they want. They just want, is this person truly depressed, or are you just sending them because they want to go?
Okay, gotcha.
So I'm gonna team William/Anna. Can you guys capture that comment from Amanda, because we can iterate on this and include that as into our updates. Like you can include a lot of detail, and then that will prove the case of the status. Love the question. Thanks, Amanda. All right, let's keep on going. We're wrapping prior referrals morning. This is in development currently for CalFresh. What we've been told from the eligibility team: do not provide a CalFresh referral if it's within 6 months. We're not going to have you remember, so we've automated this. Hopefully, this is still working. It'll track if someone did one yesterday and you do it today. It will flag you and say, wait, someone got it already within the last. This one says 12 months, but I think for you guys it's 6 months. So let me know if that's not happening. Do you guys get any other reminders for just other referrals to Recipe for Health, or is that not on right now? I wanted to kind of do a level set check with you all.
I have a quick regarding the reminder. I think what you're talking about, I'm getting it for every time, like even if there's no referral that was placed in the last 12 months. Is that's normal?
No,
Because I noticed I accidentally deleted the referral once because I didn't correctly read it before I clicked, and the default was to get rid of the referral. But I didn't realize, so I went and looked back and I thought, oh shoot, they had been referred, but they hadn't. And I think that, and then I got it a couple, I think 1 or 2 other times. So it seemed to be just giving it maybe just like an extra check that there wasn't another referral, but it was defaulted to the delete. So I don't know, it wasn't ideal, maybe.
So we're gonna go into, I'm working at the CHCN level to just deal with this across all clinics. So this feedback's super helpful. Let me clarify with you, Dr. Perry, was this about CalFresh or about the Recipe for Health?
Sorry, it was a Recipe for Health.
Okay, so I didn't put that picture up here because we're gonna try to fix that in the coming weeks. So apologies if that's not working right. We're gonna work on more details around that. We may just, because now we got the breaking news that people can get re-referred in, if you will, or get an extension, we may be shifting this whole piece and making it a shorter window, but stay tuned. And just let us know. We'll take this as an opportunity for us to look into it, and I'll work with Ryan at your, he's your director of IT, to figure out what may be going on there. All right, great feedback. All right, so more to be said about this, but hopefully if this is not working for you all, it should be 6 months for lifelong. Let us know. Again, we're at all these clinics and everyone kind of customizes. We're trying to make this standard. 2 chronic condition reminders. This is to help dummy proof, if you will. Just make it easy if you put in like an acute issue like a runny nose and you're like, oh yeah, let me get them into Recipe for Health. That's going to stop you. Red, just think red, cross, you're not going to be able to go forward. We've locked it out. And the reasoning is there. Chronic diagnosis is required. This is a program for chronic diagnoses. And if you want to do food insecurity, great, but please associate the diet of food, not only a food insecurity diagnosis, but any chronic conditions. And so this is the food insecurity one. Say your patient just has food insecurity. A lot of our pediatric patients are that. They don't have a chronic condition, but they have food insecurity. Then it will pop up and it'll just ask you, can you check though? Because if they do, it'll be covered by the health plan, which is what we want. We don't want to be using grant funds and scrambling for dollars to pay for our food insecurity. We want this to be just part of the workflow. That's a whole conversation with the state. Okay. Is this working? Kind of just a temperature check. Are you guys getting these? Is it working right? Yes, no? Maybe so. Are you guys seeing this at all? Okay, thanks, Amanda. All right, some folks are not. We're working again at the systems level to just clean it up. Apparently, when there's updates to ICD-10 every year, it may junk it up a little. So let me know. Third part, in the last 6 minutes, patient resources and reminders. This is now back to MAs. So MAs, if you've been kind of not tracking the conversation, because like, all right, I've done my food insecurity screening. Now it's back to you because you're helping to check out the patient. So, and it's reinforced by providers. So we have this website here. I'm going to save this for later. There's also in the last 5 minutes, there is a opportunity for you to get feedback on this training today. So if you don't mind just filling that out while we close this out. This is a great website. It has, and it's going to be changing. So just so you know, we're updating our website, but it has patient handouts, it has videos on how to cook, and it has our trainings for you guys. That's on the separate part, but basically patient handouts, recipes, and videos, all great for the patient. So reminders, remind the patients they must be enrolled. Dig Deep will call and text them. Open Source will call them from a 510 number. Please pick up. This is a cool part. MAs and providers, a little connection here. We have a smart phrase. It is going to be updated because the website's being updated, but it's Dr. Frankel helped set this up a while back. It's in your wrap up for the prescribers. Enter the smart phrase .R for AVS. So R4H, Respiratory Health, AVS. And what will pop up is the following, and it'll just print. And so it'll just talk about the program, the food, and the health coaching, and that they're going to get a call, and then it highlights, you got to respond. And here's the phone number if you don't hear back from them. So in a lot of the clinics, the MAs highlight this, and they just verbally go over it, and then we'll update the website, but it goes into handouts, recipes, and cooking videos. Just going to highlight the key things. They should get this within 7 to 10 days. 3, I should update that to 3 in the best case scenario. All right. Questions? Last few minutes. Putting ideas into action. This is gonna wrap it all up. So, what are the 1, 2, 3 steps? MAs. What's the first step? Screen all patients for food insecurity, just like you do for smoking at each visit. And diagnose, add the diagnosis when you can. Treat with your 2 referrals, that's it, and remind. Super simple, clear workflows between the various staff for the team-based care. Remember the key things just to make sure it goes through, double check for qualifying conditions, chronic conditions. Remember that you got the 2 gates. You got to associate all applicable diagnoses to the referral, and then you have to enter the applicable diagnoses into the clinical note. This is the prescribers. And there's a pathway for SOAP notes. We'll add the new one that you have there, and then the interim notes for it. Remember, the health plan will only cover patients with chronic qualifying conditions, and we're going to try to cover with our scarce funding. This is all in there, but it's just as a reminder of what's covered. And then my question is, in the remaining 2 minutes, how will you introduce this? What is your language? What's your opener? When you're in the middle of clinic, you're treating their diabetes. Does anyone have a nice opener they like? Bonnie, you got the feedback there. We have a 1-pager. I'll share that soon. We're working on that. Just gonna, for the sake of time, if you don't have a one-liner, I'm gonna give you one. This one has worked a lot for me when I'm in clinic. I'm looking at their labs. You may need to be placed on lifelong medications for your diabetes or your hypertension. Would you be open to an alternative? 99% of the patients I've spoken to don't want to be on meds. I have some patients, once I share the alternative, like, no, just give me the med, but it's less common. Follow-up. What's your follow-up question or follow-up to them? I can prescribe you 12 weeks of free organically and regeneratively grown food, vegetables, going to go straight to your home to treat you for your condition. Or you're eligible for free health coaching to help you eat healthier, move more, reduce stress, get support from other patients. Would you be against receiving free food and health coaching for your condition X? So these are just lines you can use. And then fog of care, this is to, and thanks, Dr. Marino. I'm usually already discussing nutrition. Fantastic. So work it in as you will. Awesome. Fog of care, when you're in the middle of clinic, we're gonna update our website, but it has all these pieces. We're updating our at a glance. So you have that one pager for the medical assistants and one page for the prescribers at MAs that can walk you through. And your goals for your clinic, 10 a week. So my ask, maybe it's too much to ask. Can you do one a day? Do you have one patient in your 12 patient, and your 15 patients, 20, 30 patients that you see, however many patients you see in a day? Can you find one patient that you think would benefit from this resource? We want to use the resource and and grow the data behind this work. All right, and then post-survey training. I know that William had already sent it, or someone sent it in our text, but if you can just get your phones out and do this, just tell me how we can make this training better. And I'm sorry, this shouldn't say nutrition education. This should just say workflow education. William, if we can correct that for the future when we send the PDF, that'd be great. And then I'm looking to improve. So how can we make this better for you? Thank you all for your time. Thanks, Dr. Sujimoto, Amel, and Naz for creating space. I hope this was useful.